Hi everyone, I'm Nikki Earle. I'm a research fellow at the University of Auckland. Thanks very much for joining us this evening, and thank you very much also to the AMRF for this opportunity to talk about heart health and some of our research, and I look forward to answering any questions you might have at the end of my talk. So just to briefly introduce myself, I work in the Heart Health Research Group at the University of Auckland, which is led by the Heart Foundation Professor Rob Doughty. I originally studied genetics down in Otago, and then I tried a few different things and travelled overseas. And then I found my way into heart research, and I did my PhD on genetic causes of sudden cardiac death. And I was supported by an AMRF doctoral scholarship over that time. And I now work as a research fellow and am again sorted by the AMRF with a Douglas Goodfellow postdoctoral fellowship. So we're a clinical research group. So we undertake studies where we're enrolling people with different types of heart disease and collecting a lot of information from them. And this is often in the hospital setting after an event such as a heart attack or an admission for heart failure. And we then collaborate with lots of other scientists and research groups to measure biomarkers on blood samples that we collect. And we also do different types of cardiac imaging on our study participants. So a quick outline of what I'm going to talk about this evening. I'll introduce some of our research and then talk about how this relates to the genetic risk of heart disease and to women's heart health, which are both areas of interest for me. And then I'll finish off with where we're headed next. So heart disease can affect people across a lifetime, and that's beginning right from babies that may be born with structural heart problems. And our research is also a program of work across different parts of the life course, but I'm just going to talk about part of it tonight. And heart health is a topic that should be important for everyone. There are currently 175,000 people living in New Zealand with heart disease, so almost everyone has someone in their friends and whānau who are affected. 1 in 3 deaths in New Zealand are caused by cardiovascular disease, and that means that someone dies from it every 90 minutes. And many of these deaths are premature and preventable. Also, unfortunately, there are persistent inequities by ethnic group and level of socioeconomic deprivation, and Māori and Pacific peoples are disproportionately affected, and they often develop disease at younger ages. So the research I'm talking about this evening is focused on coronary artery disease, which is when plaque can build up in a coronary artery that supplies blood to your heart muscle. And this can eventually lead to a heart attack where the blood supply to the muscle is restricted. So you can see what this looks like here on a coronary angiogram, which is a special type of X-ray used with dye to examine blood flow. And you can see the narrowing of the coronary artery where this arrow here is pointing. But if we get back to our life course of heart disease, there might be a person who has some cardiovascular risk factors like high blood pressure or diabetes, but they've never had a major heart event. And preventing these is called primary prevention. And there's been a huge amount of research into this in New Zealand over the past 20 years. Improving the accuracy of the prediction, and then importantly, this has already been implemented into primary care, such as GP practices. And then one of the most common major heart events is a heart attack, and there are around 15,000 hospital admissions for heart attacks every year in New Zealand. After a first heart attack, you're at much higher risk of subsequent events. And our previous research has shown that 1 in 3 people in New Zealand died or were readmitted to hospital for heart-related problems within the first year after their first ever heart attack. So preventing these events is called secondary prevention, and that's where my current research is focused. So we want to reduce the number of these events, and we also want to reduce the inequities, particularly for Māori and for Pacific peoples, and also for women. So to address this, we're undertaking a large study of people admitted to hospital with their first ever heart attack, And this is called MNZACS, which stands for the Multi-Ethnic New Zealand Study of Acute Coronary Syndromes. And this is what my AMRF postdoctoral fellowship is based around. So we're running this study at 9 hospitals around New Zealand, and we have over 2,000 people enrolled to date. So while someone is in hospital, we collect a lot of information about their medical history, their nutrition over the past 12 months and their physical activity, their family history of cardiovascular disease, and we also take a blood sample which we process and store in our biobank here at the university. So with this blood sample, we're measuring a number of biomarkers that can help to predict future risk, including several that are in the research stage, and this is including genomics or genetics, which is my main area of interest. So I'm going to talk a little bit more about that now. So I thought I'd start with a quick refresher. Every one of us has nearly 3 billion bases or letters in our DNA sequence. We share 96% of this in common with a chimpanzee, although before we start feeling too superior to other life forms, it's good to know that we also share 60% of our DNA with a banana. So humans' DNA sequences are 99.9% identical with each other, and it's the 0.1% differences that we're most interested in. So the genetic component of your risk of coronary artery disease is estimated to be around 40 to 50%, which is actually quite high compared to many other diseases. So there's some rare single mutations that can put people at very high risk, and these affect maybe around 1 in 300 people. But for most of us, the risk comes from a combination of up to millions of different sites in our DNA, each of which has a very small effect. So what we can do is to measure these sites and create what's called a genetic risk score, and use this to predict the risk of disease for any individual. So in our study MNZACS, we'll be using these scores to see how well they predict events after people's first heart attack. So which of these 3 people is the one who's most likely to die or be readmitted to hospital? And then that person could be targeted for interventions and for closer monitoring. But it's important to remember, of course, that our genes definitely don't determine our fate. So even people at high genetic risk who have healthy lifestyles can reduce their risk by 50%. And these are also the people who get the most benefit from taking statin therapy. So another area that we're looking at is giving people different medications based on their genetic profile, and this is called pharmacogenomics. So people metabolize drugs in different ways and at different speeds, and some of this is based on genetic variants that you might have, and this is relevant for some common cardiovascular medications like clopidogrel, which you may be put on after a heart attack, or warfarin, which is an anticoagulant. So in MNZACS, we'll be looking at whether people were given the most effective drug for them after their heart attack, and also looking at what difference it might have made to their outcome if we had been able to do these tests while someone was in hospital, and then they were sent home with more personalised treatments. So it's really, really important that we're doing this research here in New Zealand, as the vast majority of genetic research has been done in people of European ancestry. So what we don't know is how well all of these risk scores and tests will work in people that have different genetic backgrounds, such as Māori and Pacific peoples. Because this is so important, we're now focusing on doubling the number of Māori participants we have in MNZACS. And I'd like to thank here the Kelleher Charitable Trust, who have contributed towards this part of the study through their relationship with the AMRF as well. Another current focus for me is heart disease in women. It's the #1 killer of women globally, which many people don't know, and it kills twice as many women in New Zealand than any other single cause. But despite this, it's still often thought to be a male problem. This is a new area of research for me, but having had heart disease in my female family members and also being the mother of 2 girls myself, I've actually been quite shocked at the lack of representation of women in cardiovascular research studies and clinical trials, and also the lack of research into sex differences in this setting. So there's a number of sex-specific risk factors in women for cardiovascular disease, and many of these haven't been very well studied because of the lack of representation in a lot of previous research. So this includes things like premature menopause, which is a risk factor for coronary artery disease. It also includes a number of things that can happen during pregnancy, including gestational diabetes, which is relatively common, but also includes blood pressure problems during pregnancy, including preeclampsia. Women are also more likely to have autoimmune diseases, which increase the risk of cardiovascular disease. So in this diagram, we have these sex-specific risk factors on the left. In the middle, we have the well-established risk factors, which are common to men and women. But also on the right-hand side, we have some what they've called here under-recognised risk factors, which kind of more of the social side relating to the role of women in the family, which is often sort of that nurturing matriarch role. And this can often lead to women putting other people's needs before themselves. And so in that case, not following up on any early symptoms that they may have of disease. Women also present with disease differently as well, which can mean delayed diagnosis and treatment. And that can sometimes be women not recognising their symptoms as heart disease and not seeking help early enough. So an example of this is a recent headline from earlier in the year about a 35-year-old Auckland woman who didn't recognise her symptoms as a heart attack. She felt silly seeking help, so she didn't go to A&E. Although thankfully she did eventually visit her GP. So when we looked at how well women were represented in Men'sX, our study, it turns out we weren't doing so well, with 21% in our first 2,000 participants. And amongst these women, there were higher levels of socioeconomic deprivation than men. Women had high levels of diabetes and smoking. There was less in-hospital investigation of these women, and they had less interventions. And there were also higher numbers of women dying or being readmitted to hospital. So to try and restore some balance back into our study, we've been recently awarded an AMRF project grant, which is really exciting. So this is so we can create a new sub-study, which is called FAIR ACS. In this, we're going to double the number of women enrolled into the wider Men'sX study. We're going to be collecting data on some female-specific risk factors and look more closely at the subtypes of disease that are more common in women as well. So what's next for this research? We're continuing enrolment of Māori and Pacific peoples into Men'sX. It's been an extremely challenging couple of years attempting to undertake research in the hospital setting with COVID and lockdowns, but we're getting going again now. For the FAIR ACS sub-study, we've started enrolling women, and we've recently secured some other external funding to measure a number of hormones in the stored blood samples that we have and see that, how they relate to the age of menopause and cardiovascular risk. We've got a number of collaborations and sub-studies that are ongoing. And the nature of this type of study is that it's extremely resource intensive at the point of patient enrolment, but the value of the data grows with time. So even though we're so excited to have lots of data coming through and starting to get some results, we also have to be patient. We also have another large study, which is a randomized controlled trial looking at whether clinical management of people after a heart attack can be improved by ongoing measurement of some key cardiac biomarkers and then titrating their medications appropriately according to the results. But that's probably a conversation for another day. I'd just like to finish by saying a huge thank you to the AMRF and all of their generous donors, and also to all the other funding bodies that make our research possible. All of our studies and most of our salaries, including mine, come from competitive grants, so it wouldn't happen without the support. I'd also most importantly like to thank our study participants who are kind enough to take part in this research to help out future generations, even when they're going through such a big and stressful event in their lives. So thank you very much.